Let us investigate about pathophysiology of heart failure. The pathophysiological process that takes place in heart failure involves a complex interplay of many factors. As cardiac output begins to decline, compensatory mechanisms, both mechanical and neurohumoral in nature, are activated to sustain adequate tissue perfusion. These may initially be beneficial, but will lead to worsening heart failure over time as their ability to compensate declines. 3 most common compensations are: increased sympathetic activity, activation of the renin-angiotensin-aldosterone system, myocardial hypertrophy. Firstly, any type of cardiac damage will occur. In heart failure, the main pumping chambers of the heart, the ventricles, may become stiff and not fill properly between beats. In some people, the heart muscle may become damaged and weakened. The ventricles may stretch to the point that the heart can't pump enough blood through the body. This will lead to low cardiac output, that is a term used in cardiac physiology that describes the volume of blood being pumped by the heart, by the left and right ventricle per unit time. Cardiac output, CO, is the product of the heart rate HR, i.e., the number of heartbeats per minute, BPM, and the stroke volume, SV. Fluid retention in body will start occurring. The development of peripheral edema in patients with HF is related to fluid excess. As the heart starts to fail, renal perfusion falls. The kidneys respond by increasing the production of renin, leading to more aldosterone production, which is consequently followed by sodium and water retention. Peripheral resistance might increase. What is peripheral resistance, you ask? Vascular resistance is used to maintain organ perfusion. In certain disease states, such as congestive heart failure, there is a hyperadrenergic response, causing an increase in peripheral vascular resistance. Prolonged increases in blood pressure affect several organs throughout the body. Now, neuroendocrine activation also plays an important role. Neurohormonal activation occurs with increases in vasoconstrictors, renin, angiotensin, and catecholamines amongst. And there are many others, provoking salt and water retention and increasing cardiac afterload. This decreased left ventricular, LV, emptying and depress cardiac output further, producing greater neuroendocrine activation, so increasing afterload, etc., resulting in a vicious downward spiral. Some neurohormones are used to help diagnose the syndrome of heart failure, particularly brain natriuretic peptide. A normal level excludes most heart failure. A very raised level is strongly associated with heart failure. A mildly or moderately raised level could indicate heart failure, but equally is associated with many other disease processes. All these factors in combination contributes to heart failure. So how do we treat it? At certain point of pathophysiology, certain type of drug will be acting for reduction in heart failure. Keep this image in mind, as we will be using it frequently ahead. The classification of the drugs should also be discussed, in which ACE inhibitors include captopril, enalapril, fasenopril, lisinopril, quinapril, and ramipril. Angiotensin receptor blockers are cansartan, losartan, telmisartan, and valsartan. Beta-adrenoreceptor blockers include bisoprolol, carvedilol, metoprolol tartrate, metoprolol succinate. Aldosterone antagonists contain eplerenone, spironolactone. Direct vasodilators and venodulators are hydrolazine, isosorbide dinitrate, FDC hydrolazines, and isosorbide dinitrate. Inotropic agents include digoxin, dobutamine, milrinone, and lastly diuretics have bumetanide, furosemide, torsemide, metalazone, Now we will discuss the drugs in these categories one by one, so do watch the video till the end.